अगले वीक से अपना ब्रेस्ट फीडिंग चालू, कोई आराम नहीं।
हाँ,
कल तक ओआरएस, फिर ब्रेस्ट फीडिंग 1 से 7 तक, सब जगह एक्टिविटीज। मैम अपने को भी डब्ल्यूपीएफ में क्या अगले महीने का किसके पास है मैम? अगले वीक से अपना ब्रेस्ट फीडिंग चालू, कोई
अभी लाइव स्टार्ट हो गया है।
ओ,
It's live now. तेलंगाना।
Good afternoon, Madam Madhu, Madam.
Good afternoon, Hema. Good
Good
afternoon,
afternoon, everybody.
everyone.
Good afternoon, Madam.
Well,
Good
are
afternoon,
सीमा
joining.
मैम।
Palpa. Yeah, good afternoon, everyone. Yeah, so nice to see you, all of you.
Yeah, good afternoon.
Good afternoon. कैसे हैं
Good
रश्मि जी, कल्पना
आप
जी,
कैसे हो?
everybody? हम ठीक है, ठीक है। अब एक मीटिंग कलेक्ट्रेट को जा रहे हैं, इसलिए हम वीडियो ऑन नहीं रख सकते हैं, बट हम आपके साथ हैं।
थैंक यू।
Okay, fine.
यस मैडम। अल्पना, श्रीलेखा, हाउ आर यू?
मजे में। हिमा,
हाँ,
ये लाइव स्ट्रीम हो रहा है।
ओके ओके, सॉरी।
Yes. Now you can start the meeting. Okay. We are YouTube live.
I'm starting. Good afternoon, all dignitaries, faculties, audience. On behalf of Women Pediatrician Forum, in this 9th webinar of the current year 2026. The name is Monsoon and Child Health by WPF MP State. Monsoon is a season of joy, greenery, and refreshing rains. However, it also brings a surge in illnesses among children due to contaminated water, increased mosquito breeding, and changing weather conditions. From diarrhea to respiratory infections, from dengue to malaria, from enteric fever to leptospirosis, there is a significant burden of these illnesses in children and healthcare system. So this webinar aims to revisit the common monsoon-related healthcare problems in children and discuss practical evidence-based strategy for prevention, early identification, and management. Besides, world has also celebrated WHO ORS Day and ORS Week in last few days in fond memory of Dr. Dilip Mahanabilis. So WPF has planned this webinar keeping this concept in mind. With this, I hand over to our chairperson, Dr. Madhu Raturi ma'am, for her welcome address.
Hello, dear. Good afternoon, everyone. On behalf of PF, I welcome you all this afternoon for a monsoon talk, which is a bit trippy but very important for all of us. The topics taken, because as we all know, prevention is better than cure. So our MP team, thank you so much for selecting this topic. It is our effort to keep everyone updated regarding the latest trends in the treatment, prevention, different vaccines which are there. And I hope there are so many dreaded diseases which are waterborne, foodborne, vector-borne, environment, everything. And I believe with our speakers will be talking about the newer vaccines regarding vaccines against dengue as well as malaria. And I believe the scenario will change. The disease burden will reduce, which is very, very high, especially of dengue. So hope to uh, think about that. Thank you very much, Team WPF, Dr. Srilekha Joshi, uh, Dr. Alpana Shukla, Dr. Shweta Anand, Dr. What is the name? Silky and Dr. Rashmi Gupta for taking up this topic. Let us go ahead. Over to Dr. Anuradha again for speakers.
Thank you, ma'am. Thank you. I'm sure our team will rock in this webinar. Now I invite Dr. Sangeeta Lodha ma'am, immediate past chairperson, for talking about this webinar, discussing
Yeah.
in brief.
Very good afternoon to all the respected dignitaries and the members from MP Women Pediatricians Forum. And I hope that this program will go very successful, because this is the need of hour to talk about monsoon. We all know that this year the monsoon has come in a blast, and the speakers will give justice to the topic. And without wasting any time, I just hand over the mic to Dr. Anuradha Sanadhya and request her to just proceed for the uh, program. Thank you. Thank you all.
Thank you, ma'am. Our senior ma'am and founder chair, Dr. Hima Bindu ma'am, has also joined. I want to listen few words from her also as words of blessing.
Thank you, Dr. Anu, for involving me and personally inviting. All the very best, only very short. I would like to say WPF is really doing great work under the chairmanship of Dr. Madhu Madam. As always, we are touching upon very important topics. And I'm very actually excited and appreciate that the state chapter is now coming forward. So we have been doing so many programs at national level. MP, WPF is doing this. So listening to this, I'm really very much happy that we should improve our state cadre and work towards strengthening. And as community is important, this topic is also very important. Let us now look at what the WPF MP is telling, asking us to do regarding handling monsoon issues. All the best. Thank you so much.
Thank you so much. Now it is time to start the webinar itself. The project coordinator for this webinar is Dr. Alpana Shukla, who is also happens to be Joint Secretary of WPF. And the moderator will be Dr. Srilekha Joshi ma'am. Now I hand over to Dr. Alpana Shukla ma'am for further conduction of session.
Thank you very much, ma'am. Thank you, Dr. Anuradha. So a very good evening, respected Dr. Madhuranduri ma'am, our chairperson WPF, as well as our esteemed members also who are present here for the webinar today. This scientific session is from MP WPF team with our honorable moderator, Dr. Srilekha Joshi from Indore, our energetic speakers, Dr. Rashmi Gupta from Gwalior, Dr. Shweta Anand from Bhopal, and Dr. Silki Agrawal from Indore, and myself, Dr. Alpana Shukla from Chhindwara. The monsoon season, as we have all been talking about, while bringing relief from the summer heat, it also brings a rise in the infectious diseases, the diarrheal illnesses, vector-borne, and so many health challenges. And as pediatricians, of course, as Madhu ma'am said, it is our responsibility to stay updated with the latest evidence and practical approaches to manage the prevention of the infections. So today's session has been thoughtfully planned to cover three important areas of concern, along with the ORS Day and Week, which is being celebrated by the IAP from 25th to 31st of July. Prevention of disease during monsoon will be taken by Dr. Rashmi Gupta. ORS and diarrhea control and prevention from Dr. Shweta Anand. Dengue, which is a very common infection this season, its approach and management by Dr. Silki Agrawal. With this, I now invite Dr. Srilekha Joshi, our moderator from Indore. She's a senior pediatric consultant in Indore, Madhya Pradesh. She is the chairperson of MP IAP Respiratory Chapter also, and she's a very vibrant practitioner and a member of IAP. She is the past joint secretary also of this WPF body of 25-26, and also she has been the AB member of IAP 24-25. So welcome, Dr. Srilekha ma'am. You can now start and conduct your session ahead.
Good evening. Very warm welcome and heartfelt regards to all my dear friends in this webinar series. It is said that knowledge is just like an infinite sea without any boundaries. The more you dive into it, the more and more pearls of wisdom you are going to pluck. So our WPF scientific series is purely meant to serve this purpose. And I'm very sure that after attending this session, we'll be able to plug the wisdom pearls, which will be helpful for all of us in our day-to-day clinical practice. We know that epidemiological triad of disease includes agent, host, and environment, three factors. And the interplay between these three factors, it is responsible for occurring of any of the disease. So during monsoon, all these three factors: agent, host, and environment. They are favorable for all the diseases, whether it be respiratory disease, waterborne disease, or vector-borne disease. There is, first of all, there is susceptible host, which in the presence of conducive environment is responsible for causing any disease in the presence of a proper agent. During monsoon, we know that environment is such a favorable thing for all the diseases, as presence of humidity and warmth. That is, it is not too hot or not too cold. These two things are very much favorable for growth of any bacteria, virus, fungi, or protozoa. So host factor is very much favorable. Stagnation of water and collection of water everywhere, it leads to breeding of mosquito and thereby propagation of all vector-borne diseases. And thirdly, because there is fluctuation in temperature, there is humidity, there is dampness. It leads to decrease in immunity as we talk of the host factor. So all these things together, it lead to proliferation and propagation of all these fungal, bacterial, viral infections, which involve actually different systems of the body. So we are covering here the first topic, that will be taken by Dr. Rashmi Gupta from Gwalior on prevention of diseases in monsoon. Dr. Rashmi Gupta is a very renowned figure, multifaceted personality, and she doesn't need any introduction to our house. But as a formality, we'll just give her formal President, AHA Gwalior, Branch 2019, President, Gwalior Academy of Pediatrics 2009, Organizing Secretary, 2007. He is faculty in various national, international conferences, webinars, CMEs, and workshops. And she has delivered in different capacities in different workshops and seminars and conferences. She is actual ALS, BLS group in charge of IIP-MP group, and she has conducted more than 50 CPR mass awareness programs. She has received many honors and recognition, including Mother Teresa, International Women Achiever Award, Rotary and Lions Club Award, COVID Warrior Award, and Times of India Icon Award. So over to you, Dr. Rashmi Gupta from Gwalior. Dr. Rashmi?
Thank you, Dr. Srilekha, for such a nice introduction. I hope it was long back. Now I'm not doing anything much nowadays. So I will start sharing my PPT, okay? So first, let me thank the organizers, especially Dr. Alpana, who gave me this opportunity. She was the first one to talk to me, and Dr. Srilekha also, and Madhu ma'am also. And I was like a convener from MP when Poonam Bhatia was national, something like that. But I didn't do anything. But this time, thank you very much. I got an opportunity to speak on this topic. So shall I start?
Yeah.
Yeah, ma'am, I cannot see my slide. I have shared.
We can see it, ma'am. We can see it.
Slide is visible. Slide is visible.
But I am
We
not
can see
able
it.
to see. I don't know why.
Arpana madam, can you hear?
हाँ, I'll try it. हाँ, पर उनको फिर share बंद करना पड़ेगा, then only I
Have
can
you done
try.
screen share
No,
first?
I'm sharing. Yes, I have shared.
You stop the
It's
share
seen?
and then again share.
Is it seen? I'm
हाँ,
sharing.
We can see.
Okay then.
नहीं नहीं आप
Okay, no
करो ना.
problem.
Start it. I'll start it. Okay.
Yeah.
Oh, something is happening. Okay, okay. Got it. What
Madam,
I'm
change the
doing.
slide. Come to the next slide, whether it is moving or not.
Can you see my slide?
Yes, we can
Yes,
see, madam. You
yes,
just
yes,
move the
we can.
slide.
Why can I not see my slide? Oh, what is happening? Okay.
आप करिए.
पता नहीं क्यों नहीं हो रहा शेयर, दिख ही नहीं रहा मेरे को.
Madam, go to the screen share mode.
Ma'am,
Slideshow mode. I think you are not in slideshow mode, madam.
I am in slideshow mode. Wait, I'll close everything. You know what I have done? I
Yeah,
have closed my video. That's why. Oh my
Ma'am,
God.
you have in the screen you will see settings part and go in that settings part, share screen option, and then
I have
like you have
already done it. I have already done it, Beta. I have already done it, but something wrong is in this. I have clicked some different. Okay, shall I close it and start again? I'm sorry, I'm wasting
madam.
time.
We will wait for a second. You just stop sharing and then reshare.
Okay.
Stop sharing and reshare.
Something is happening. I'm sharing. Remove.
Madam, stop share.
It never happened like that, yaar. Never
It happens,
happened.
madam. It's a mad.
Can somebody else take the responsibility of sharing all the slides? As our generally tech takes the responsibility. This glitch,
रश्मि
you
मैम
know,
आपने ऑफ किया क्या? रश्मि मैम आपने ऑफ किया?
सारा खत्म हो जाता है शो.
दिख रहा है क्या?
Yes.
Yes.
रश्मि मैम, you can continue, I think. आया
Okay,
क्या?
now Alpana, you keep on sharing slides
हाँ.
of all.
Yes.
Okay.
हाँ. रश्मि मैम, you can start. रश्मि मैम आउट हो गए क्या?
Yeah.
Can you see?
Yes.
हाँ.
दिख
ये
रहा
मैंने
है ना?
शेयर किया है रश्मि मैम.
तो ये दूसरा है बेटा, ये हमने थोड़ा सा चेंज किया है इसमें.
Okay. Rashmi
तो
ma'am,
यहाँ
can you
पे-
go with these slides? Can you go with these slides? Can you see?
ये
हाँ,
आपने जो
ये
मुझे
सेकंड
भेजा
को
था.
बता. हमने जो लास्ट वाला भेजा है ना, वो शेयर कर दो ना आप.
ओके, फिर मुझे नहीं, वो थोड़ा सा अभी एकदम से लाने में दिक्कत होगा मेरे को. क्या होता है कि उसको हम इसमें खोल के रखे रहते हैं लैपटॉप पे एक कोने में.
अच्छा, नहीं
ऑल्टर
वो
टैप
मेरे
करके
से
उसके
यही
अंदर.
करते, पता नहीं क्या मैं कोई बटन क्लिक कर दिया है जिससे ये प्रॉब्लम हो रही है. एप्पल में यही प्रॉब्लम होती है. तो आप है ना इस बार एक बार शेयर करना बंद करो ना प्लीज. लेट मी
हाँ.
डू इट नाउ.
ओके ओके, यस यस यस, प्लीज डू इट. आप ट्राई करो.
आई एम सॉरी फॉर दैट. आई विल गो हरी अप.
हाँ हाँ, कोई बात.
No problem, madam.
कोई
Take your time.
आराम से करो मैम, रिलैक्स.
Yeah, relax. Don't worry because it's a technical glitch and can come anytime because it is a human-made
Can you see
machine.
this? Can you see my slide?
Yes.
आप उसको होल्ड स्क्रीन करिए
Yes.
मैम. आर ग्लास. यस यस, डन. वेरी गुड.
Done ना?
Yeah.
हाँ हाँ. आपसे
वो
मूव हो रहा
मैंने
है.
ना कोई बटन वाली अपनी वाली हटा दी
Okay.
थी. That's why
Rashmi
this
ma'am, are you
happened.
comfortable?
So thank
Are you
you very
comfortable?
much. I'm starting. I'm starting.
Yeah.
Yes.
We have already wasted so much of time. Thank you for this waiting for me for this presentation. I really wanted to do it myself only. So my topic is prevention of. First of all, I have thanked everyone, and thank you now also everyone present here who bared my problem with me. Thank you so much. And then today's my topic is prevention of childhood diseases during monsoon. And I'm going to discuss about practical pearls for pediatricians. And we all of us know that बारिश, मिट्टी और मासूम मुस्कान यही तो है बचपन की सबसे खूबसूरत पहचान. And we have to give them great guidelines to how to protect themselves, to the parents, how to protect their kids. And so here we go on. So Why does monsoon matter? We know that there is an increased risk of waterborne disease like acute gastroenteritis, cholera, typhoid, hepatitis A and E, and then foodborne diseases like these are also causing this only: cholera, typhoid, hepatitis E, and acute gastroenteritis. And then vector-borne disease like dengue, malaria, chikungunya. I'm talking about only India. And the airborne diseases like viral URTI, influenza, and COVID can anytime erupt, and respiratory syncytial virus infections. And then the others are leptospirosis, which is a zoonotic disease, and I will not go in detail. And this is scrub typhoid. It's a bacterial infection spread by this red bugs, and skin infections and conjunctivitis. And so let us see the prevalence. It is this chart has been taken from IDSP, and you can see from 2022 to 23, this is data of 23, that there's increase of 32% in dengue cases. Acute diarrhea, there is an increase of 18%, malaria 9%, ARI 7%, and conjunctivitis 15%. And out of all this, you can see children account for 40% of total monsoon-related cases. So it's an alert for all of us to keep them safe. Now, what are the 5 safe practices? It's like safe drinking water. We all of us know about this. We have to drink clean, boiled or treated water. Avoid stagnant water like empty cover or clean containers regularly. Food hygiene, we know that, we all of us know about it. Eat freshly cooked food. Wash fruits and vegetables with clean water. This is very important to remember. And tell the parents also they need to clean with RO water or boiled water or anything like that. Not like that, the tap water, okay? And keep surroundings clean, proper waste disposal. We all of us know about this. And wash hands with soap and key. That we all know. That's very simple, but it's very important. Keep germs 80% away from our kids. Gut and respiratory system and everything. Now, prevention of gastrointestinal infection. Along with all that 5 safe practices, we need to tell them that they have to continue with exclusive breastfeeding. And then ORS, Dr. Shweta is going to talk about this in detail. And zinc therapy. This is very important because it is also given, not, it mends the endothelial tissues. It's not only important for this GIT, but all respiratory infection. And rotavirus vaccination, we all of us know. I'm not going to go in detail in vaccination. And the clinical pearl is that we should take every opportunity, not only to counsel about diarrhea, but all other monsoon-related diseases to the parents. It is very necessary. Counseling helps, you know that. Now, respiratory infection prevention. We know that hand hygiene, apart from those 5 safe practices, we need to tell the kids, the parents to tell the kids that they should know about respiratory etiquette, like they should cover mouth or nose while coughing and sneezing, and use tissue or elbow if they don't have it. Then they need to avoid crowding, good ventilation, we all of us know about it. Adequate sleep is needed, and balanced night we know. Now, vaccination is the extra layer for protection. We all of us know about this. Little bit I will talk about vaccination later on. Now, skin and eye care. That fungal infection, common monsoon problems are like in these only fungal infection like ringworms, athlete foot. The common one only I'm discussing. I'm telling you. Impetigo, that is honey-colored sores on the face, mouth, anywhere you can get this. And scabies, you all know. I will not go in detail. Cellulitis and conjunctivitis. So, what will you advise the parent to take care of their kids? What will you advise them? So you need to tell them to keep dry skin after rain or bath, dry skin thoroughly, especially the skin folds. We do forget to wipe off this skin folds, and tell them armpits and like inguinal pits and all everywhere they have to dry it very nicely, and they have to put a moisturizer. That is also very, if a dry skin irritates the child more than the washing, you have to moisten the skin. So change wet clothes, change out of wet clothes immediately to prevent infection. Avoid sharing towels, we all of us know. And seek early medical care for any rash, redness, swelling, or eye symptoms. We all of us know that happy and healthy child is a beautiful child. So preventing vector-borne diseases. Dengue, we have to take 5 key practices. We need to keep dry our homes once a day. We don't need to water our plants and all. Or then you empty coolers once a week. You need to wear full sleeves. Mosquito nets has to be used, and then window screens. That is also very important thing. And malaria, 2 key practices we need to follow. One is insecticide treated bed nets or sleeping while sleeping, and then indoor spraying as per the local guidelines. Now, DDT is not used. It is replaced by deltamethrin, DEET, Picardin, and we know about that patches, mosquito repellent patches, where the eucalyptus is laced with lemongrass, citrulina, or neem oils. So, practical advice: empty flower pots and trays at least in 5 days. Cover all water container. Discard old tires. Clean roof gutters. Change water in vases and bottles regularly. बल्कि ये तो आपको डेली ही करना चाहिए. And avoid water logging. So we need to break the life cycle of Aedes mosquito. Actually, Silky is going to take in detail about it. I will just talk about little about it. We know that Aedes breeds in clean, stagnant water. Eggs survive 6 to 12 months in dry container walls. Eggs hatch when containers refill with rainwater. Adult mosquito emerges 7 to 10 days depending on the temperature. Bites mainly during early morning or late afternoon. So what we have to do, we have to clear your containers 5 to 7 days. Every container with water, every cooler should be cleaned and emptied every 5 to 7 days to break the cycle. In this image, you can see that cycle can be broken between larva and pupa. At this point, so it is 5 days now. It is saying 5 days. So every 5 to 7 days, you need to change the water. So there are some genetic engineering going on in lab to kill this oh my goodness, kill this mosquitoes. What they do, these male mosquitoes, they are sterilized, and they are given thrown in the community so that they mate with the wild female. And what they do, only the eggs which are produced are non-viable, and this non-viable eggs die soon. So there is decline in mosquito population, Aedes mosquito population. And what else they do? They infect a male mosquito with Wolbachia bacteria. This is a virus series, blocks virus replication. And when this mosquito बेचारा जब female से मिलता है तो it kills virus inside this. So the Aedes population is reduced. But this technology only supplements, but does not replace source reduction, environmental sanitation, or community participation. So that is very necessary. Now, vaccination for dengue and malaria, you know that Qdenga and Dengavix, which is going to be detailed by, I think, Dr. Silky is going to detail it. And for malaria, we have this Mosquirix and Matrix M, but this is not included in NIP and ACVIP, and it is not freely available in India also. So what is a red flag recognition? Persistent vomiting, severe, tell the parents about this. Persistent, if there is persistent vomiting, severe dehydration, fast breathing, altered sensorium, convulsions, bleeding, severe abdominal pain, or poor output, they have to consult their pediatrician. So key message to parents are: don't ignore these nasal signs. Seek medical care early. Timely treatment prevents complication. When in doubt, consult your pediatrician. So for mnemonic for monsoon, you need M stands for mosquito control, O stands for ORS and oral hydration, N stands for nutrition and normal growth monitoring, S stands for safe water and safe food, O stands for observe danger signs early and go to your pediatrician, and O stands for ongoing routine immunization, and N stands for don't take unnecessary antibiotic for the viral infection. So बरसती बूंदों में बचपन को मुस्कान दीजिए, मिट्टी को सौंधी खुशबू में सपने को सजाने दीजिए, बस सुरक्षा और स्वच्छता के हाथ थामे रखिए, यादों को जीवन भर महकने दीजिए. Thank you.
Thank you, Dr. Rashmi, for such a wonderful presentation. In short time, you have covered so many things. And you have given us update about Aedes mosquito sterilization and newer vaccines and everything. So thank you very much. And with this, we move to our next topic. We know that due to improvisation of sanitary condition, inclusion of rotaviral vaccine in national immunization program, and public awareness, the incidence of diarrhea has reduced drastically. If we see the incidence as well as mortality due to diarrhea in under 5 children, almost 80% reduction has been there in last few decades. And whenever we talk about diarrhea, the 5 things which come in our mind is first is fluid, food, flies, finger, and feces. So about all these things and diarrhea control and prevention, Dr. Shweta Anand is going to tell us. Dr. Shweta Anand is Professor Pediatrics in LNMC and KK Hospital, Bhopal. He is very young, dynamic, and always shining personality. She has been Joint Secretary of MPIP, instructor of IIP, CPR, ALS, and NRP programs. And she had been editor of MPIP magazine Harmony for so many years. And she is holding this responsibility very efficiently. So over to you, Dr. Shweta.
Thank you, ma'am. Thank you. May I request Dr. Alpna ma'am to share the slides, ma'am, if possible? Ma'am, Alpna ma'am is there?
Yes. Is it visible?
अल्पना यार तुम्हारा मार्क्स तो हटा
Yes,
दो,
ma'am.
हम लोग इन्फेक्शन
Yes.
नहीं देने वाले तुमको.
Sorry, ma'am. Sorry, ma'am. दिख रहा है ना, ma'am?
Yes, ma'am.
Visible?
It's visible. Yes, ma'am. Yes. Good afternoon, everyone. Topic given to me is ORS and diarrhea control and prevention. I heartily thanks Women Pediatric Forum, especially Madhuri ma'am, Sangeeta ma'am, Hema Bindu ma'am, Srilekha ma'am, and Lina ma'am for giving me opportunity. Already some points have been discussed by Rashmi ma'am regarding ORS. I will talk regarding in detail. I will say the ORS to be medical miracle. Why so? Because the ORS was a history that was a breakthrough not only in the 20th century, still the innovation is going on, and still in the 21st century, this innovation will continue. Next slide, Alpna ma'am. The
Move नहीं हो रहा है.
maybe yes, the vision was started from the WPF forum in collaboration with the IAP, because this I am fortunate enough to celebrate the ORS week celebration with my topic, and thank you ma'am also for giving me opportunity. It has been this week celebrated from 24 July to 31st July, and yesterday was the ORS day. Next ma'am. The ORS history started way back, ma'am, when in Sushrut's time, there the coconut water was used as a therapy for the diarrhea. After then, Hemendranath Chatterjee, 1953, David Nalin also worked hard on ORS, but the contribution goes to Dilip Mahalanambe's previous slide, ma'am. Dilip Mahalanobis, who started his ORS invention in 1971 in the Bangladesh Liberation War, where the water was very scant, hygiene was not maintained, and cholera was on rise. So his invention made the cholera mortality reduction from 30% to 1%. So yes, Dr. Anuradha ma'am has already said regarding the contribution of Dr. Dilip sir and his memorable interventions for the ORS celebration. Finally, the advocacy of this Dr. Dilip Mahalan in this was done by Dr. Dhiman Baraua. His advocacy pushed the ORS into community-based care. What he did was he made the diarrhea disease control program, which was implemented in 1978. And we started training layman person with the ORT, which made a global death decrease to a very, very lower extent. That is why under 5 mortality, which we used to read was diarrhea, now because of this ORS invention went down, and pneumonia is now the major killer. Next slide. So coming with the pathophysiology of the ORS, you can see this beautiful diagram which has been studied by all of us way back. You can see the 3 parts. On the left side is the lumen, where we ingest or we take the ORS. ORS basically contains sodium, glucose and water. In the intestinal epithelium, this is the cell with a villi, projections are there which makes everything to be absorbed. And finally, these all like glucose, sodium, water gets into the blood. This blood is finally the extracellular fluid, which is indirect marker of the hydration. So what we do it is we have to replenish this blood of the extracellular fluid with the water. So what is the magical therapy of this ORS is we have this sodium glucose transporter channel. What is the beauty is it allows the glucose mediated transport, and it allows the one glucose to go with the one sodium and a passive transport of water. So this is what a role of ORS, where the osmolality should be maintained, because the osmolality totally depends on 2 into sodium plus glucose, which we all are reading. That is why we try to maintain the passive water drive and prevents the dehydration. So the ORS basically decreases the dehydration, but not has very good effect in stool reduction or volume reduction. Next slide. Now we have lot of ORS. What I said is we have to make the ORS which should make the blood osmolality match. Normally, what is the blood osmolality of us is 290. Standard ORS was made specifically with osmolality of 311, which was very good for cholera, because that time cholera was very high cause of diarrhea during previous years. So there was a loss of too much of water, sodium, potassium. So glucose. So standard ORS was good for cholera. But with time, we understood that this osmolality don't match with the blood osmolality. So we should invent some ORS which should match or lower down, so that the risk of hyponatremia is less, risk of vomiting is less. Then came the invention of low osmolarity ORS, where the osmolarity is around 245 with glucose and sodium of 75 milliequivalent. Here also sometimes the problem is if your child is malnutritious. So sodium will be always high in malnutrition, potassium is low. So there came the invention of Resomol. Resomol was a rehydrating solution for malnutrition child, where the sodium is almost half, potassium is almost double, and small amount of magnesium is added. So these are the type of ORS. Next slide, ma'am. These are which we are using. Now comes the role of some inventions which are still in pipeline. I just want to say in 2003 and 4, the government of India has particularly labeled ORS to be used by all age group for all type of diarrhea is the low osmolarity ORS. Still these all type of ORS which I have presented in the previous slide, the low osmolarity is the WHO ORS which has to be prescribed by all of us, and it can be recommended for all age. Now, what is this super ORS? So, super ORS means something which is more additive or adjunct or added on to the normal low osmolarity ORS. So, what you can see in my three figures, like in the first orange color on the left side, the ORS has been added with zinc and lactobacillus. Yes, probiotics are somewhere help in the gut dysbiosis and help in the prevention. Sometimes it happens that ORS and zinc will be a better, but disadvantage is because child will be taking lot of time, so it may be difficult to have a zinc in a proper way. Second comes the role of rice ORS. Rice ORS are some complex type of carbohydrates, which I will in further slides will help you that maybe in future era, rice ORS may replace low osmolality ORS. Third one is amino acids, like I have shown in the pathophysiology that there is a glucose sodium symporter channel for absorption of water in ORS. But along with that, other transport channels are there, like in amino acid, we have alanine, glycine, lysine, glutamine. They also lead to a water import channel and leads to water drive. So we can have other channels can be used to take the water in drive during the diarrhea. Next slide. So what is the role of this rice ORS? Rice ORS means a polymer-based carbohydrate or a ORS which are more carbohydrate with a complex preparations. Normally this orange color this balls you can see, they are the normal low osmolarity ORS, which use only one channel to use and drive the water. But what happens in the lower side is a complex carbohydrate. So you can see the rice yield more glucose molecule upon digestion without increasing the osmolarity of the solution in the gut, thereby enhancing overall water and the sodium absorption. But problem with this rice ORS, it should be readily made, immediately made, short shelf life is there, costly is there, and slightly cumbersome. So still they are all under inventions, not to be recommended. It is just for the presentation and for the more scientific informations which may in future may help to replace this low osmolarity ORS. Next slide. So what is there is just experimental studies have been done which showed that with the rice-based ORS, there was 100% improvement in the recovery as well as there was a more superior electrolyte balance. So still the trials are going on. Maybe in future we get the same slides to be learned by. Next slide. Next, this is what is I want to highlight. This is what is normally what is the main problem in us in a pediatric age group of diarrhea is dehydration, and water absorption, as we all know, is through colon, large intestine. But what we are dealing till here, up till here, was targeting small intestine. So what is this amylase resistant starches? They get converted into short chain fatty acid, and colon has a good power that short chain, these starch will bypass the small intestine, go into large intestine. Large intestine, this amylase resistant starch will convert into this short chain fatty acid, and there will be a good water drive into this. So the absorption will be more common, more easy. But thing is, important is again the same. It has to be readily prepared. Under experimental studies are there, but yes, when pathophysiology are understood, these are maybe a new era dietary soluble fibers, that is a short chain fatty acids, may replace this glucose sodium channel because water absorption through the colon will be the highest. Next slide. So again, just summarizing, maybe in future this standard WHO low osmolarity, yes, we all know fluid absorption is best, but with super ORS, because low osmolarity ORS targets only one channel, that is the glucose sodium channel. But here with the rice and amino acid, we are using multiple pathways. So what we get is we will be having extreme enhanced absorption of the fluid. Stool volume we don't target in low osmolarity, we just target about the dehydration. But with the rice-based ORS, amino acids, the reduction in the stool volume is observed by 30 to 40%. Even the diarrheal duration was shortened significantly when you use super ORS. Nutritional value is high when you give a cereal-based and amino acid. So still, these are all experimental based, evidence based, but maybe in future super ORS may supersede the low osmolarity ORS. Next slide. Now, big question is to use 1 liter or 200 ml. When you have a ready prepared formula, no at all issues, because you have a targeted packet where you have to dissolve 1 liter and a 200 ml packet with a packet to be dissolved in a glass of water. But what happens is people are not clear of 1 liter water. You can see here lot of jars are there where the identity for 1 liter is absolutely not clear. And normally what we see is in under 5 mortality, the weight of the kg of a 5-year-old child will be approximately 15 to 18 kg. So if you go with a no dehydration, the child will hardly consume 500 ml. So you will almost waste 500 ml and there will be discarding. So what you do it is, you can use 200 ml better choice if you have, but if you don't have, just main the standardization of 1 liter. So I think I would just want to say that 1 liter may be a big problem, but for sugar salt solution, when we prepare a home-based remedy, it becomes very easy. 6 teaspoon of sugar with half teaspoon of salt. But when you use 200 ml, 1.2 gram of sugar with 0.1 gram of salt, it becomes very difficult to titrate the two things. So for home sugar salt solution, which we have in the leaflet, which we propagate, is for SSS, sugar salt solution. You can use the 60 SF. But when you have a ready-made formula packets available, which are freely available at all CHC, PHC, I would recommend a 200 ml a packet ORS will be a better choice as compared to 1 liter ORS sachet. Next. So the big study was done in 2023 by the Zambia in a kit Yamu packet. So what you can see, this is one of the packet beautifully designed with a measured 200 ml jar, and they have a ORS packet of 200 ml and zinc tablet. Somewhere or the other, they have made a packet to be distributed to every kid who have acute diarrhea, and they made it sure that this concentration, everything was explained beautifully to the parents. And next slide, ma'am. So what they observed is when they give the same packet with ORS and zinc, the behavioral accuracy came out to be 93% more. So always the designing packaging, which we may also do it in India, like packaging with the measuring jar. Normally, some of the companies are giving the jar with 200 ml, but zinc is not there. So maybe in future, if we can give a big, good designed packets of both ORS, zinc, and accurate measuring jar, maybe our more result, more behavioral accuracy, and more better outcome will be there. Next slide. So yes, if we don't have this prepared ORS, already we know each and everything. Never ever give soft drink, sweetened teas, sweetened fruit drinks, coffee, or any tea or herbal drinks. What is there is sugar and salt solution, chahe छाछ दें, coconut water दें, rice water दें, dahi दें, but never a sweetened drink should be given. It leads to more dehydrations. Next slide. This I contribute to a pediatricians. Being pediatrician, I also feel proud. The person from Hyderabad, Dr. Sivanjini Santosh ma'am, who fought for 8 years to mislabel this sugary drink as ORS. Finally, her fight became fruitful, and the Indian regulatory body, that is the food safety regulatory body, banned ready to use unless their formulation match new WHO ORS. So thanks to ma'am for your fight, and fortunately we were able to get this all packed sugary item to be out of this new WHO ORS. Next slide. Finally, I finished my slide. This is the beautiful picture made by my PG for the official publication of the Women Pediatric Forum, Dr. Nisha Rajput. And what I want to say from this picture is that mother, if healthy, the child will be healthy. You cannot pour from an empty cup. Taking care of yourself is a form of strength. First, love yourself. Nation will be healthy, community will be healthy, family will be healthy, and kids will be healthy. Thank you so much.
Thank you, Shweta, for such a wonderful presentation. Very excellent presentation. And
Thank
you
you,
made all the things very simple one for us. And you had given us a clear idea about super ORS, which
Thank you,
we
ma'am.
all should know. So thank you very much. And now we are moving to the next topic, that is dengue. We all know that dengue has undergone lot many twist and turn in last 2 decades, and actually management protocol has been revolutionized like anything. And if we see the incidence of dengue, it is coming down. In 2023, it was just 2.89 lakhs, and deaths were 485. In 2024, 2.33 lakhs with 297 deaths. In 2025, 1.21 lakhs cases were there, and with 131 deaths. And in 2026, till February 2026, 6,927 cases have been seen of dengue. So to know something about dengue approach and management, I request Dr. Silky Agrawal to deliver her lecture. And Dr. Silky is very efficient, enthusiastic, and energetic personality. She has done her pediatric infectious disease fellowship after completion of MD Pediatrics. At present, she is running Chaitanya Clinic at Indore. She has been faculty in various regional and national ID conferences. There are various publications in Index Journal, mainly focused on primary immunodeficiency and complicated infection. She has contributed to infectious disease chapter in IAP textbook. So I request Dr. Silky to deliver her lecture on dengue approach and management.
Ma'am, my screen is visible.
No, not visible.
Wait a minute. Now is it?
No.
अभी डेस्कटॉप दिख रहा है आपका?
दिख रहा है ना? हाँ,
डेस्कटॉप,
डेस्कटॉप
yes.
दिख रहा है, अभी स्लाइड्स नहीं आई.
Madam, click over the presentation and go to the slideshow mode.
Just over it now.
No problem. Take your time, no problem.
Yeah, is it?
Yeah.
Yes, उसको
Now
आप
go to
hourglass
slide
कर, हाँ,
seven.
yes.
Perfect.
Okay, fine, ma'am. Ma'am, thank you for the opportunity to be present on this platform. I'm really glad and thankful to everyone, Dr. Madhu ma'am, Dr. Srilekha ma'am, Dr. Alpana ma'am, and everyone. Let's start without wasting time. Problem statement, I think Srilekha ma'am has already spoken about it, but just to highlight that dengue problem, I think we will never be free because India contributes maximum cases, like 34% of the global cases are contributed by India, being the South Asia country. And we have seen gradually, annually, the cases have been increasing. As per last data, it's almost 1.5 times in 2023 compared to what was in 2019. And it's also important that when we see a dengue case, there are always, for a one dengue case, there are 200 to 300 unreported cases. So we may never be free of this dengue problem. And that's why there is a need for vaccine. And we should be vigilant about whenever a child presents with fever, we should suspect dengue. So whenever we see a dengue case, dengue viral infection, it could be asymptomatic or symptomatic. It is important here again that of all the cases we see, there are 90% asymptomatic cases, and of them only 10% are symptomatic. And even of that 10%, majority are undifferentiated fever, and only a small percentage of them will be dengue fever without warning sign, and again minor percentage will be the complicated dengue cases. So when do we suspect dengue? According to the WHO and various guidelines, we should suspect dengue in any child who present, child or any adult who present with fever, high fever, and who is in the endemic area or who has a history of travel to dengue endemic areas. This applies to non-endemic countries. And along with fever, they have any of the two symptoms of the following six. Is there nausea, vomiting, or any kind of rash, any body aches and pain, or specifically retroorbital pain? We all know. We can do a tourniquet test if there is CBC done and there is leukopenia, or if there is any warning sign. This is initial febrile phase rash, which is can be said as quite classical for a dengue fever. It blanches on pressure. It's fine maculopapular rash due to high fever. It suggests high likelihood of dengue. In 2009, the WHO came with a newer classification of dengue and has simplified a lot of things. It classified dengue into dengue without warning signs and with warning signs and severe dengue. In this, compared to previous classification, which did as dengue without warnings, means dengue without any complications, and complicated dengue, it classified into dengue hemorrhagic fever and several grades and followed by severe dengue. So this was simplified by this 2009 WHO classification. The important here is when the patient has some any warning signs, as shown by the smaller circle here, that is any abdominal pain or tenderness, vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, hepatomegaly, or rise in hematocrit. See, these are very easy clinical signs with which you can classify the patient into dengue with warning signs. And once you know that the patient has any of the warning sign, you are alert that the patient has entered into the critical phase. And once the patient has entered into critical phase, there are high chances that this patient can go into severe dengue presentation. So both we have to be cautious for patients with warning signs, and we need to admit these patients with any of the warning signs, making with this classification, identifying patient with warning sign was made easier. What are the criteria for admission for any suspected dengue patient or any patient proven for dengue? So if there are any warning sign, you have to keep the threshold lower for any patient who are infants, obese, or who have comorbidities, because again, these class of patient have a high chances of going into complication. And obviously any child with signs of severe dengue. What do you do when you suspect dengue in any child? So if there are no warning signs, as stated earlier, we should not go for any CBC. That may not be helpful because there may not be changes. Most important part when when you're suspecting dengue in any child on initial days, you have to do parental counseling. That there is a role of lot of fluids that will prevent dehydration. They can include things like soup, ORS, juices, and especially you should tell them that you should avoid sugary or juices or fluids. And also, instead of plain water, they should go for home-based fluids like ORS. Fever, there will be high fever, so the patient should be counseled that you need not be worried about fever. It may not touch the baseline, and you should use only paracetamol and no other antipyretics like ibuprofen or mefenamic acid, because they may increase the risk of platelet dysfunction and increased risk of bleeding. All the warning signs, as mentioned, they should be explained to the parents in a comprehensive way, and you should cross check that they have understood it. One simple warning sign that can be explained to a parent is that if they have not passed urine in the past 6 hours, encourage them to look for this. Keep a chart at home also, how much the child is taking and urine has been passed in the past few hours. What are the few objective clinical parameters where you can identify that the child has entered into critical phase, other than those warning signs? One is if the platelet count is less than 1 lakh, hematocrit is rising by more than 20% if you have any baseline CBC. And if you don't have any baseline CBC and the hematocrit is more than 40, this child is likely in critical phase. Third, if you see in ultrasound any pericholecystic collection of fluid or ascites and pleural effusion, this child is into a critical phase. And fourth, hypoalbuminemia if you have any LFT star. So what are the management principles in a critical phase? This is most important thing which is given by the Sri Lankan guidelines, which is one of the most recognized guidelines for dengue fever management. So in this guideline, what they have mentioned is you should calculate fluid quota. That is the maintenance fluid for that person plus the deficit, which is usually 5% of the body weight, which you calculate by 50 ml into body weight in kgs. Secondly, most important thing is you should use adjusted body weight if the child is obese. And this can be done by the formula 0.4 into the difference between the actual body weight and ideal body weight and plus the ideal body weight. Thirdly, meticulous monitoring cannot be under highlighted because it's the most important thing. Fourthly, fluids, there is no fixed formula for fluid administration. It should be, as you monitor, it should be guided by the clinical condition of the child, by the blood pressure, by the peripheral pulses, and well as the urine output. So, how this formula came of the quota, that maintenance plus 5% body deficit? So, what is first? Let us know that what happens in dengue that is in the critical phase and that leads to severe dengue is plasma leakage. So, the idea of giving fluid is to maintain the organ perfusion. It is never to increase the blood pressure or giving the fluids will not reverse the capillary leak. So, idea is to give just appropriate amount of fluid to maintain the organ perfusion. And because we know this plasma leakage is temporary and occurs only for 24 at max 48 hours. So what happens is this 5% came from because they've seen in critical phase around 3 to 8% of the plasma leak of the fluid loss occurs as in the form of plasma leakage. And so this 5% deficit was added to be replaced in the entire critical phase, that is around 24 to 48 hours. Using this quota rationale, you can mitigate the risk of fluid overload. So what is important is maintaining circulation and not just flushing the individual with fluids without any principle. So, fluid management in critical phase. If the patient is not in shock, the choice of fluid will be a dextrose normal saline. so that you can maintain even the sugars, and you're not using it in higher rates. You should use it as low as 1.5 ml per kg per hour. Previous were the days where you used to use for 3 to 4 ml per kg per hour, but now because we are once aware that it can lead to fluid overloads, and since the patient is not in shock, we should go as low as 1.5, and that too, if the patient is able to take orally, we need not give intravenously. Always calculate the total fluid quota once the patient has reached to you, as well as especially once the patient is entering into the critical phase. Use urine output and perfusion status in non-shock patient to guide the fluid rate. As if the patient is taking orally well, you can stop IV infusion. Target urine output to 0.75 to 1 ml per kg per hour. If it is less than 0.75, you can increase the rate. If it's more than 1, you should decrease the rate. If the patient is shocked, this again is taken from Sri Lankan guideline, which are very comprehensive. If the patient is entered into shock, we classify the patient into whether it is in compensated or uncompensated shock. For compensated shock, we can say that pulses are felt, but pulses are feeble, but BP is low. The narrow pulse pressure is there. So for this kind of patient, we will give a single bolus of 0.9% NaCl, that is normal saline, at 10 ml per kg over 1 hour. And we see for the response, if there is response, you should reduce the rate according to the hematocrit and vital signs. If there is no response, you can give another bolus only at the rate of 10 ml per kg, again at for 1 hour, and again assess for the response. If there is no response, no need to see. The idea is if there are two boluses and there is no response, you need not give the third bolus. Reason being, whatever fluid you are giving, it is leaking. So better it is at this stage, you can switch to dextran, that is another colloid fluid. Now we come to, if it is a profound shock patient, you can increase the bolus rate to 20 ml per kg, and it is given at a free flow rate. It is not for a restricted time. It is given for a free flow rate. Reassess the patient clinically. If there is response during fluid or at the end of 20 ml per kg, you reduce the rate and continue monitoring. If after the end of 20 ml per kg first bolus, there is no response, you need to be more aggressive and you immediately shift to dextran 40 at 10 ml per kg over 1 hour. And again, after 1 hour, you reassess for response. If there is still no response, you need to see other things which are contributing to shock, like acidosis or bleeding. Also check for electrolytes as well as blood glucose. If there is response, you can switch to a normal saline, again tapering the amount of fluid. Few things about dextran 40. This is to be used only during critical phase and also in patient with shock. It is not to be used in non-shock patient. Infusion rate to be kept only to 10 ml per kg and to be given over 1 hour and not faster than that. The expected drop is 8 to 10 from pre-infusion value, but if the drop is more than 10 and patient has not improved, there could be concealed bleeding. Maximum dose we can use of dextran 40 is 3 boluses in 24 hours or 6 for the over 48 hours. There are many complications of dengue, but I'll discuss about the most common about bleeding. When do you suspect? It can be a concealed bleeding or it can be overt visible bleed. Concealed bleeding, you can suspect when there is drop in hematocrit with worsening or no clinical improvement, or a rapid drop in hematocrit after giving a dextran bolus, or if there is continuing metabolic acidosis or end organ dysfunction like liver and renal dysfunction or failure, despite adequate fluid, there could be concealed bleeding. So what do you use? You use only packed RBC. It is the most appropriate thing to be used if you are giving it for bleeding. Or if it's not available, then you go for whole blood. If there is a suspected bleed and hematocrit is very high, rather than going for PRBC at first, go for dextran first so that the hematocrit drops. Otherwise, there could be complication related to hemoconcentration. Give initially at the rate of 5 ml per kg over 1 hour, and you need repeat only if needed if the patient is stabilized, you can switch to other safer fluids like dextran or normal saline. So platelets only if it's like less than 10,000 and along with there is visible bleed or patient is in shock. So these were the charts given by again Sri Lankan guidelines. These are very comprehensive. We can get it get it online. This makes it easier dengue management and what could be the expected complication, as well as there is space for fluid quota and you can note down whatever fluids are given and the expected deficit, as well as what over amount of fluids has been given to the patient. So coming to next, briefly about dengue vaccines. There are many dengue vaccines in pipeline, which are also in preclinical or phase 2 trials. But today I'll be taking only the vaccines which are completed almost phase 3 trials. And in fact, Qdenga is the vaccine recently approved. Now,
College of Medical Science, Bhopal.
We have Dengavaxia, which is going to be history now. It was approved in Brazil and many of the countries other than India for use. But because of its limitation of antibody-dependent enhancement, the complications like severe dengue post-vaccination after few years is the limitation related to Dengavaxia. When the Dengavaxia was given in immunological, previously non-infected cases, so Dengavaxia used to serve like primary dengue infection, and subsequently when the patient encountered dengue, wild type dengue virus infection, they were more likely to get severe dengue infection. So this was the limitation of Dengavaxia, because this Dengavaxia was built on the backbone of yellow fever vaccine. So, yellow fever virus. So it was a chimeric virus synthesized by yellow fever backbone, and we use the membrane proteins of dengue virus to synthesize this Dengavaxia. So what happened is non-structural proteins of dengue virus were not included in the Dengavaxia virus. So still it was live virus vaccine, but it did not have non-structural proteins related to dengue virus. So the antibodies produced were not sustained and long-lasting related to Dengavaxia. This limitation was overcome in Qdenga and Butantan vaccine. Qdenga and Butantan vaccine, both these vaccines are built on live attenuated dengue virus structure. Qdenga uses dengue virus 2 and Butantan uses all the 4 dengue viruses which are attenuated. So they have immunity, they have antibodies against non-structural proteins also. So neutralizing antibodies in Qdenga and Butantan are better compared to that of Dengavaxia. So serostatus testing, that is the status of the individual, whether it was previously infected with dengue or not, is not required in Qdenga and Butantan, which was required in Dengavaxia. Also, dengue virus 2 protection is superior in Qdenga and Butantan because the structure is itself dengue virus 2 in Qdenga. Dengue virus 2 is one of the virus that contributes to severe dengue in a higher rate. And that's why we need a lot of protection. It will be fruitful only if any vaccine is giving protection against dengue virus 2, which was not the case with Dengavaxia, and that's why it failed. WHO, Qdenga is WHO pre-qualified. Butantan is still to clear a lot of stages before this achievement. Efficacy wise, Qdenga is superior. 80% overall for all the serotypes and 90% prevention against hospitalization. So Qdenga and Butantan vaccine are going to be the future. In fact, Qdenga is the present now. They are both have attenuated dengue virus backbone, so they have durable promising efficacy against all 4 serotypes, unlike Dengavaxia. Qdenga and Butantan are safe. They do not show the antibody-dependent enhancement phenomena, and they do not require serostatus testing before administration. And there are no complication expected so as per recent whatever results are there. But few cautions in Qdenga vaccine which may come in future. So this was Qdenga was licensed after TIDES trial, that is tetravalent immunization against dengue virus. This trial was done in 4 to 16 years age group. It did not include any individual more than 60 years. So using it in elderly more than 60 years should be avoided until further data is available. Vaccine efficacy is poor in previous dengue naive individual. It was also found that if the individual was previously non-infected, they had lesser, the vaccine showed lesser efficacy, especially poor against dengue 3 and dengue 4 serotypes. After 4.5 years, the data showed that vaccine efficacy was again lower in dengue naive individual, that is only 50% compared to 63% in previously infected. And there was no protection against virologically confirmed dengue in dengue 3, dengue naive individuals. They were not infected by previously dengue. Query, there could be risk of antibody-dependent enhancement phenomena or severe dengue years after Qdenga. We don't know. So far, we have data around 7 years. But if there is no booster dose, what after many years of forgotten vaccination, if the patient gets infected with dengue virus, will there be antibody severe dengue risk? That is still a query for all of us. So still we should be thankful whatever we have with a strong data now. Dengue vaccine is the shield now, and as per maybe we soon be having in our shelves. So let's go for it.
Thank you, Dr. Silky, for excellent presentation. And I would really like to appreciate the efforts done by Dr. Rashmi, Dr. Silky, and Dr. Shweta. They have done full justice with the topics given to them. And as I already said, we will really pluck wisdom pearls from your session, today's session, that will be useful for all of us in our day-to-day clinical practice. So thank you very much, Dr. Silky. And with this, now I hand over to Dr. Alpana Shukla for further proceedings.
Thank you, ma'am, for the opportunity.
Thank you very much. My special moderator and my speakers, everything was very fine, and really each topic was covered so efficiently and from each and every nook and corner of the topic. Thank you very much, all my speakers. I will hand over the session to Dr. Ramya now for a vote of thanks, as we are already very late. And Dr. Anuradha, can we take a collective pick of the whole?
Anybody, any
Yes,
questions?
please switch on your camera.
Thank you so much, dear. Just a minute.
Dr. Rashmi Dwivedi has
all three of you have
also
done justice to the
She want to
topics.
speak.
Any question by anyone? You have covered the latest, and especially in the dengue, all the vaccines and everything. Let's see how it works. Wonderful team MP. कोई क्वेश्चन पूछ रहा है तो देख ले, अदरवाइज लेट्स मूव ऑन टू
चैट बॉक्स में तो कोई क्वेश्चन नहीं है.
थैंक्स. चलिए ठीक है, ओके. पर्सनल लेवल पे भी पूछ सकते हैं और लेट्स मूव ऑन टू थैंक यू. माय फर्स्ट पर्सनल थैंक टू द टीम टोटली.
Please switch on your cameras. Done. So Dr. Ramya for the vote of thanks.
Ma'am. On behalf of WPF, I thank everyone for this opportunity that I'm having. I would like to thank our chairperson, Madhura Aturi Madam, for this wonderful monsoon academics. I thank the past chairs, Sangeeta Lodha Ma'am and Hemubinder Singh Ma'am for their presence. I extend my wholehearted thanks to Alpana Shukla Ma'am and her whole team of Madhya Pradesh for their wonderful job. Srilekha Joshi Ma'am, who did a splendid job as a moderator. And given the insightful updates, I would say the speakers, Dr. Rashmi Gupta Ma'am, Shweta Anand Ma'am, and Dr. Silky Mitra. Thank you all, and you've all been a wonderful audience. Thank you, ma'am.
Thank you.
Anuradha ma'am, can you close up?
Yes, yes. I
Thanks
shall wind up
all,
the program.
all
Thank
who
you
are
everyone for
attending.
joining.
Thanks all who are attending for their